Bismillah ar-Rahman ar-Rahim. I'm Dr. Mohammad AlAlshaik from King Fahd Medical City. My subject today is local regional therapy of HCC. Excuse me for the slides. Could you please yeah, here we go. So nothing to disclose. As you know, HCC represents one of the few cancers for which local regional treatments are recognized as being able to cure or prolong survival and are included in the international guideline. This is due to the unique nature of HCC. In most cases occurring in patients with underlying virus or alcohol-related cirrhosis, the treatment choice in patients with HCC is therefore driven not only by tumor staging, as in the great majority of cancers, but also careful evaluation of liver function and physical status. Another specific feature of HCC is that it is the only tumor that can be cured by organ transplantation with the aim of treating both the cancer and underlying liver disease. These characteristics configure a complex scenario and promote the need of close cooperation among different specialties: hepatology, pathology, interventional radiology, radiology, oncology, and hepatobiliary surgery. For the epidemiology of HCC, as you know, is the most common primary liver malignancy. Only for resection, the rate of recurrence can be as high as 50% at 2 years. Only 12% are eligible for resection or for transplant. 80 to 90% of HCC cases occur in cirrhotic liver. Decision-making for treatment of HCC is supported by guidelines endorsed by different societies worldwide. Differences in recommendation among guidelines mirror differences in cancer epidemiology and technique availability and expertise in different countries. The Barcelona Clinic Liver Cancer Classification has emerged during recent years as the standard classification that's used for clinical management of patients with HCC. And here is a brief table of this classification. And as we know, the local regional therapy play a key role, especially in early stage A and intermediate stage B. Types of local regional therapy of HCC, we have two types: the percutaneous ablation and transcatheter therapy. Percutaneous ablation like chemical ablation, ethanol injection, thermal ablation, RFA, microwave, cryoablation, and also now there is a new non-chemical, non-thermal ablation techniques. Also for the arterial therapy, we have TACE, radioembolization. I will concentrate mainly for the ablation for the sake of the time in the RFA and microwave for the ablation. So RFA is well known from 1990 and was approved by FDA in 2001. Simply the technique or the idea of RFA induced thermal injury through a delivery of electromagnetic energy, application of rapidly alternating current between the generator and the needle and the ground pads. Unfortunately, I don't have the pointer. It forms a closed circuit between these components, and then we'll have an ionic agitation inside the tumor, which generate heat, and then we will have the effect that we want. Temperature is very important. So the table here shows the tissue reaction for various degrees of thermal injury. Our ideal range is between 60 to 100 to have a coagulation of the tissue. We don't want less than this and don't want more than this. So Monitoring the temperature itself is important during the procedure. We have different systems. Here is an example of two systems. We have the cool tip and the Levine electrode. The system dependent, it's operator dependent, what system he preferred, and the availability of the system itself. So simply we place our needle by using guiding, either CT guiding or ultrasound guiding, place our needle, and we start the ablation. At the completion of the ablation, and this is during the procedure itself, we try to see the reaction and the effect of RFA. And usually there is the mass become echogenic due to microbubble formation, and subsequently the electrode is withdrawn by applying additional lower energy during the withdrawal to prevent seeding of tumor cells in the needle track. And here is an example. You can see in the first image a small nodule of HCC in the right liver. After that, a needle and the tip of the needle in the second one. And the third one, we can see the microbubble formation. CT, enhanced CT after 1 to 2 months is recommended to see if there is a residual disease. If there is a residual disease, multi-sessions of RFA is also possible. Another important issue of RFA, which is the heat sink effect. Heat sink effect, it is a phenomena when the tumor itself is closed from an artery or from the vein. So the blood will take out the heat, so the thermal injury will be less. So this is called heat sink effect. And this is decrease the efficacy of RFA. So we try to augment the efficacy of RFA by doing some tips and tricks and some techniques by, for example, use balloon occluded RFA. We put our balloon in the artery and the hepatic artery, and we start RFA, or in the hepatic vein or portal branch. Also, we can, if the tumor itself is closed from gastrointestinal structure, we try to displace this gastrointestinal structure by creating artificial ascites. And here is an example. We have a tumor in the segment 7 of the liver, and in the ultrasound image, there is a hepatic, right side hepatic vein close to the lesion. So in the third image of the angiographic image, we can see there is a balloon, and in the same time, there is our needle. And here is the result after 2 months with complete ablation. Complication, we have RFA is with complication rate of 7% and very low mortality. Different complication, thermal injury, skin burns, post-ablation syndrome, hemorrhage, infection, and tumor tract seeding. I will go to the microwave ablation. Microwave ablation refers to the use of electromagnetic method. It offers many of the benefits of RFA and has several other theoretical advantages. One of the advantages that higher intratumoral temperature, large tumor ablation volume, faster ablation time, ability to use multiple applicator, and improved convection profile, optimal heating of cystic mass, and less procedural pain. This slide shows that the technique of microwave, applying of microwave field cause water molecules to rotate billions of times. So with the kinetic energy leads to heat generation. The second diagram would show the needle of the microwave with the heating zone around the needle. And one of the disadvantages of the microwave is the heating around the shaft of the needle. But nowadays, with the new system, there is a pump which reduces this heat, so reduce the skin burn itself. Coming back to the heat sink effect that we spoke about it in the RFA, microwave appear to be more apt to overcome perfusion and large heat sink than other heat-based ablation modality. Microwave energy has been shown to ablate tissue up to and around large hepatic vessel measuring up to 10 millimeter and create larger zone of ablation in high perfusion area. Here is another example. In the first and second image, arterial and venous phase pre-treatment. And this is a post-treatment. In the last image, there is a lack of enhancement. Recent systemic review and meta-analysis of microwave ablation versus RFA doesn't show, it shows similar efficacy between the two percutaneous technique with apparent superiority of microwave and large neoplasm. Ethanol injection, this is an old technique well established for the treatment of nodular type HCC. 5 randomized clinical trials showed that RFA has higher anti-cancer effect than ethanol injection, still used in Asia. I will go directly to the TACE. The rationale for TACE is that the intra-arterial infusion of drugs such as doxorubicin or cisplatin mixed with lipidol followed by embolization of the blood with gelatin sponge particle or other embolic agent will result in a strong cytotoxic effect combined with ischemia. And this is, we call it conventional TACE. Nowadays, there is another technique, or which is called DCB, drug-eluting microsphere, has provided a valuable alternative and has replaced conventional regime at several institutions. Before go to the image, cumulative meta-analysis of multiple studies, however, has clearly shown that 2-year survival of patients with HCC not suitable for radical therapy who are treated with arterial embolization or chemoembolization is improved compared to the conservative management. Here is an example of TACE. We can see a tumor in the dome of the liver with contrast enhancement. We were not sure if it is HCC, but the enhancement and the presence of hepatitis C virus. We did a selective catheterization in the second image, which show hypervascularity of the tumor or tumoral vascularity. The third image or the second image on geographic show it after injection of lipidol with doxorubicin. The fourth image with CT scan approve the good captation of lipidol in the CT scan, and this is the optimal result that we want. The DCBs, as we said, it's the same idea, but the idea here, this microsphere will have the ability to actively sequester the doxorubicin for longer time and with low toxicity. So this is also another example. We can see the liver tumor. The first, the MRI show hyper enhancement and wash out, and then selective embolization of the tumor treated by TACE. There was a trial compared both DCBs and conventional TACE. There was actually no significant statistical difference between both of them. It showed some superiority of the DCBs regarding the toxicity and liver toxicity. So some people now, they prefer to keep it for the patient with child B. A lower rate of doxorubicin related side effects, also for more selective catheterization, especially there is a difference in the price between both of them. Radioembolization is defined as the infusion of radioactive substances. Currently, the most popular radioembolization technique use microsphere coated with 98 yttrium, a beta-emitting isotope, giving the hypervascularity of HCC. Microsphere injected intra-arterially will be preferentially delivered to the tumor-bearing area and selectively emit high-energy, low-penetration radiation to the tumor. There are 2 types nowadays in the market, which we have TheraSphere, which is a glass, and Cerasphere, which is made of resin. 2 absolute contraindication. The first contraindication is the hepatopulmonary shunt when it is more than 30 degrees. The second one is inability to prevent deposition of microsphere to the gastrointestinal tract. Serious complications have been reported as a result of untargeted radiation, including cholecystitis, gastric ulceration, gastroduodenitis, pancreatitis. This step done, or this technique done in 2 steps. The first step is mapping angiography. So we bring the patient, we do mapping angiography, we see the anatomy, we see any branch going to the gastroduodenal structure, we try to close it, like here, the gastroduodenal artery, number 1, has been closed by a coil. Then we inject 99 technetium to do the scan to see the hepatopulmonary shunt. The second step, bring the patient again, and we start our procedure, radioembolization, like the steps of the TACE. And here was a tumor in segment 4 with thrombus in the portal vein. It was treated by radioembolization, and the last image showed after 22 months a good result. Comparing both the technique, radioembolization doesn't include the fizzle at the arterial level, so option for repeat embolic treatment, less ischemic damage, response rate seem to be similar, no head-to-head comparison, equivalent side effect profile. Also, we should not forget the availability of the radioembolization and the price of the radioembolization itself. I will go quickly to trying to place these options according to the BCLC. It is difficult because it is debatable, and there is a lot of debate regarding this, but I will try to go with you through this classification. Very early stage, as we know, surgical is, according to the European Association and other guidelines, these patients can be offered surgical resection if they have cirrhosis, but still have well-preserved liver function. But in non-ideal patient with impaired liver function, RFA or ablation in general will play a good role. In patients with very early HCC, the complete response rate approached 97% with 5-year survival rate of 68%. Microwave also play the same role. Both techniques achieve the same effectiveness. In early stage HCC-A, also resection and transplantation produce the best outcome of well-selected candidate with HCC. But also in non-ideal patient, 3 randomized trials have provided conflicting result. And comparison between ablation and resection in nodules more than 3 centimeters in size is not correct, as it will known that the RFA success rate dropped dramatically for technical reason. Also, the rate of failure of ablation also increased in the case of multinodular HCC. But the author or the conclusion from this, it depends on the location of the tumor. In fact, they concluded that minimal invasive in surgery should be favored in patients with peripheral HCC, like in segment 2 or 6, while RFA should be preferred in centrally located tumor. So it's still debatable.
2 minutes.
Okay, intermediate stage HCC, the recommendation for TACE as the standard of care for intermediate stage HCC is based on the demonstration of improved survival compared with best supportive care or suboptimal therapy in meta-analysis of 6 randomized clinical trials. Still, there are some absolute and relative contraindication exist, including tumor burden, size more than 10 centimeter, thrombosis of portal vein. Advanced stage, systemic therapy, according to Barcelona classification, with sorafenib is considered the therapy of choice for patients with advanced HCC. Very recently, regorafenib has been approved as a second-line treatment after sorafenib failure. Stage C, still there is a place for TACE and radioembolization in stage C. And I will show you a big clinical trial, which is called the SARA trial, happened in 25 French centers through 4 to 5 years. Compared sorafenib versus radioembolization in advanced hepatocellular carcinoma showed that radioembolization doesn't increase overall survival in patients with advanced and inoperable HCC who failed after 2 rounds of TACE compared to sorafenib, but offer higher tumor response, better tolerance with less treatment-related adverse event, and better quality of life over time than sorafenib. Conclusion, disciplinary approach and collaboration is important in HCC management. HCC program, as an example, it will be a good start. Local regional treatment, as you know, play a key role in the management of HCC. Image-guided tumor ablation is recommended in patients with early stage HCC. When surgical options are precluded, TACE is the standard of care of patients with asymptomatic multinodular tumors. Radioembolization is a promising option for advanced stage. Okay, thank you.